Thanks, David, for introducing and for your for today our lecture, and welcome everyone, and thanks of our speaker from US to join us for this trauma study program, particularly today, and for providing our educational support to our trainee and our doctor during this difficult time. So, Lieutenant Dr. Medis and all and Dr. Davis for organizing this. So we have some, if you have questions and answers during the session, you can put in the function you call the screen, and you can, Dr. Davis can coordinate with that. And so I would like to introduce our speaker. Today we have a speaker from Dr. Fairfield Scott, who is also the professor and vice chair of the education and division of trauma and acute care surgery and Baylor College of Medicine, and section chief of trauma surgery department of surgery and also Baylor College of Medicine. After completing his MD from University of Texas Southwestern Medical School, they have a training from Baylor College of Medicine affiliated hospital. The Scott clinical and research study focus on station of trauma patient, care for the open abdomen, on methodology of complex abdominal wall construction, as well as the surgery of the focal, and he also a recipient of the multiple award for clinical and teaching excellence. Our next speaker is Dr. Johanna Kudzik, MD, MBH, who is also an medical degree from Emory University, Atlanta, Georgia, and she completed both general surgery residency and surgical critical care fellowship at the University of North Carolina, Chapel Hill. During her research fellowship in residency, she also earned a master's degree in public health with concentration in leadership of health, and also served as a trauma and fellow at the Kamuzu Central Hospital in Malawi. Other quizzes interest include emergency general surgical condition, the care of critically injured trauma patient. So we have other discussion less, as you all know, that methods or and also other eminent discussion as well. So without further ado, I'd like to hand over to Dr. Davis from Benton Hospital, who is also one of the outstanding trauma surgeons in the Benton Hospital, who will serve as the moderator for today's discussion. Dr. Davis, and thanks for coming to us again, and over to you.
Great. Thank you very much, Dr. Host. I know that Dr. Scott is logging on now, so if we can get started with chest trauma by Dr. Grinchiak, that would be fantastic.
Okay. I am going to share my screen. I think I'm going to share my screen. Sorry, here we go. Okay, can you all see this? Rachel, you can see that? Okay, hello everyone. Thank you for that introduction. I am Joanna Grudziak. I am currently an assistant professor in trauma and acute care surgery at the University of Utah. Did my training at UNC Chapel Hill and spent a year in Malawi doing mainly an administrative burn fellowship. So it's an honor to be here. Please ask any questions you might have. I try to make this fairly approachable and try to be cognizant of potential limitations and resource and availability of basic resuscitation. So hopefully this is applicable to the challenges that you all are dealing with. Let's see. My objectives today are mainly just to discuss the thoracic injuries that become an immediate threat to life, and the ones that could be addressed with treatment that's relatively uncomplicated. So we'll go through the pneumothorax, tension pneumothorax, hemothorax, open pneumothorax. We'll talk about rib fractures and flail chest, and then I'll briefly touch on cardiac tamponade, other organs that could be injured in the chest, and resuscitative thoracotomy with the caveat that a lot of these latter points are really only applicable in settings where you have advanced ICU care and availability of a blood bank, et cetera. So that may not be applicable to the realities in which you practice. Just a brief review of thoracic anatomy. Lots of things hide in the chest, lots of big potential spaces to bleed into, as well as organs that are immediately life-threatening if injured. You have the bony thorax, which becomes very important with rib fractures, obviously, and protects your intrathoracic organs. You obviously have the heart and the lungs, as well as the major vessels here, which you can see with the brachiocephalic vein, the aortic arch, and the main pulmonary arteries here. Mainly the trauma mechanisms, obviously, that we worry about are penetrating and blunt. Penetrating trauma to the chest, about 30% of it in developed, or in higher income countries requires an operation. Blunt trauma, only about 10% of it requires any kind of an operative intervention. Penetrating, you can divide it into stab and gunshot wounds with high and low velocity, as well as impalement. And then blunt trauma, obviously any kind of car accidents, assaults, crush, and blast injuries will fall under that. With any trauma, we have the golden hour during which we can intervene. The pre-hospital deaths are mainly caused by a devastating major vessel injury, bad head trauma, or complete C-spine injury. If the patient gets to you and they're severely injured, you do have that golden hour to intervene on the A, B, C's, D's, and E's of ATLS, so advanced trauma life support. A is airway and B is breathing. And today we'll mainly be focusing on breathing and a little bit on circulation, because these are all interrelated. So with that, obviously, the first thing we wanted to talk about is a pneumothorax. So this is an accumulation of air in the thoracic cavity outside of the tracheobronchial tree. So when I talk to my patients, I tell them it's, you normally have air in the chest, but this is air where it shouldn't be. The mechanism of a closed pneumothorax is injury to lung parenchyma, most commonly from rib fractures, but can also be from penetrating chest wounds and penetrating mechanism, or just from the severe deceleration, acceleration, or a blast. You can also have injury to bronchi and the trachea, causing an air leak. And this is in blunt trauma. This is the most common thoracic manifestation of blunt trauma, blunt chest wall trauma. You diagnose this in the trauma bay usually during your initial evaluation. Again, breathe for breathing. You would have decreased breath sounds, potentially crepitus, bruising, or any kind of signs, obvious signs of trauma, hypoxia, and respiratory distress. We all get a chest X-ray in our trauma evaluation, but ultrasound is actually better at diagnosing a pneumothorax. It's much more sensitive and almost just as specific as a chest X-ray. I have a video to play. Bear with me for a second, please. Let's see if it'll work. Okay, so let's see if I can figure out how to share this part of my screen. All right, so this is, can y'all still see this? Okay, great. This is a normal ultrasound. You can see this bright white line, that's the pleura, and this is sliding back and forth with inspiration. And then, let's see. And on the left-hand side of the screen becomes a little bit abnormal, but this is easier to see here. Sorry, this is the normal lung sliding, which is easier to see on this ultrasound. And that denotes that the pleura can independently move and the lung can expand, with the difference being with a pneumothorax, your pleural line is essentially immobile. There's no lung sliding on this view, and that's how you use it on ultrasound to diagnose pneumothorax. Let's see. Back to this. the other kind of sign that we talk about is the waves on the beach sign. On the screen left, you can see normal, and on the screen right, you see abnormal appearance of the lung with the pneumothorax. On a chest X-ray, it's fairly obvious. This is a very large right-sided pneumothorax. You can see the lung collapsing here and a dark space here indicating air. A special kind of this is a tension pneumothorax. So this is the point that we talk about a lot with life-threatening pneumothoraces. They develop over time in spontaneously breathing patients. And if you do end up with hypotension in a patient that's spontaneously breathing, this is a late sign and it's ominous. It can be rapid in intubated patients because of the positive pressure, ventilation, and you have the classic tracheal deviation away from the involved sign. So this is, again, a chest X-ray demonstrating, you can see the trachea deviated over here and a large pneumothorax over here. Similarly, on this side, here's your pneumothorax and your tracheal deviation. Finally, hemothorax, accumulation of blood, obviously, in the pleural space. This is the second most common cause of preventable combat death and the third leading cause of combat death overall. This is, again, either injury to the parenchyma, which is low pressure, or an injury to arteries that reside in the chest. These can be the intercostal, internal mammary artery, or pulmonary arteries, and these are high pressure systems. You can diagnose it with diminished lung sounds, hypotension, hypoxia, and respiratory distress, but also with imaging again. Your chest X-rays here show massive hemothoraces, and on the ultrasound image here, you can see pleural fluid and a little bit of the lung and liver here. The treatment for all these is the venting of the chest or drainage of the chest. So in our trauma bay, we can do this with either a chest tube or most recently, also with a pigtail if that's available. Those are recommendations. They're most recently updated from the Eastern Association of Trauma. Our normal drainage systems can do suction. They can water seal, and they have a collection system. What happens if you don't have these? You can improvise them. So 1, 2, or 3 bottles will do. If you only have access to a single bottle, you can treat a pneumothorax, a hemothorax, empyema, or an effusion fairly adequately. The problem here is that if you only have one small bottle and you're draining a large effusion, you're going to need to change these bottles out fairly quickly. And you only want a little bit of water in the bottom here of the bottle, because the more water you put in there, the harder it is for the air to drain. So that's the other caveat here, is that if you're draining a lot of fluid, you're going to have to change it out, because otherwise you're going to compromise your drainage of your pneumothorax. This simple one is made of just a bottle, a blunt needle here and a blunt vent here with some IV tubing and a drinking straw. And it's the IV tubing that would attach to the patient. If you have access to 2 of these or a saline bag, you can improvise a drainage system. So this is a 2-bottle system or a bottle plus a bag. The bag then provides your water seal, and the bottle provides your drainage system. This does not allow you to titrate suction. So if you hook this up to a wall suction, you can cause trauma to the lung. But the advantage here is that you don't have to change out your bottles quite as quickly or as often, because you can hook this up to an empty water bottle and have your water seal improvised with the saline bag if that's available to you. And then finally, if you do want to use suction, you can use the 3-bottle drainage. It's a little bit more complicated and it requires more holes and more tubes. But you basically improvise a water seal tube, a collection bottle, which goes to the patient, and then the 3rd bottle, which goes to suction. You can titrate the suction here by how far you fill the water column in the suction bottle. And it will not go above the centimeters of water that you've filled it up here. So anything above it, it'll just drain out of this suction bottle. So you will not be causing trauma to the patient. So you can improvise these in an emergent setting. Some other notes for hemothorax: if you have massive hemothorax, which is defined as having an initial output of 1,500 cc's or ongoing output of about 150 to 200 cc's per hour for 2 to 4 hours, you need to explore the patient if you can, because that indicates a major injury that needs to be operatively addressed. And then if you have And if you have a retained hemothorax, if you have the availability of doing a VATS earlier is better. If you have the tension pneumothorax physiology in the field, so you have someone who's hypotensive and you think they don't have breath sounds, you decompress them bilaterally with a needle. You can do this anteriorly or in the normal anterior axillary line that you will place a chest tube in. And this will temporize the patient until you get them decompressed properly with the chest tube. Special note on the sucking chest wound. So this is a large communication of the external world to the pleural cavity. The reason this is important is because you can suck air into the pleural cavity. This will then collapse the lung and air won't be able to escape. So essentially you will create a tension physiology. You treat this with a non-occlusive chest dressing. So this is a vented chest seal, meaning it's closed on 3 sides and has a little vent for the valve, the air to escape, but not be drawn back in. And then you also want to place chest tubes away from the site of injury. And then if you have availability, you do want to take these patients to the OR to explore them for exploration and washout and repair. Finally, rib fractures. These don't get a lot of, they're a little bit less exciting because you don't normally need to intervene on them, but they are very common. They're usually the most common manifestation of trauma, and especially in the elderly, that happens to the thorax. Usually you manage these with very aggressive analgesia, which can be very significant requirements because these are very painful. Early ambulation and mobilization and supplemental oxygen. If you do have respiratory compromise from these, it's usually because of an underlying pulmonary contusion and not because the mechanics of the chest wall, with the exception of a flail chest, which is defined as a fracture of 2 or more ribs in 2 or more places. And what this causes is a paradoxical chest wall expansion, which is the opposite of what you normally do when you take in a breath. The treatment here, again, is analgesia mostly. If you do have access to an ultrasound and medications that you can instill into the nerves, you can perform an intercostal block. But if you don't, then whatever you can use is perfect. A lot of these people require intubation and mechanical ventilation if the flail is significant enough to cause respiratory compromise. And then fixation of the ribs is not necessary, but if you do have it available, you can consider it if you're having trouble weaning off the vent. Cardiac tamponade, I'll just fly through this because we're almost out of time. Normal amount of pericardial fluid is about 15 to 50 cc's. The diagnosis is by Beck's triad at the exam. This is sometimes really hard to see or hear, but it's defined as muffled heart sounds, dilated jugular veins, and hypotension. You should be able to see this on the FAST exam. And the treatment for this that's life-saving is a pericardial decompression. But unfortunately, this is a little bit difficult to do in situations where you don't have access to the operating room. You can needle decompress these patients by inserting a needle under the xiphoid pointing to their left shoulder and aspirating. You will know that you've hit the heart or the muscle if you attach an EKG electrode to the needle and you see a tracing with SD segment elevations. If you do see that, back it out, and then you will know that you're in the pericardium itself. However, this does not treat injuries that cause ongoing bleeding. It's more of a diagnostic tool or a temporization tool if you have someone who's crashing and you can take them to the operating room later. If your FAST is positive, this patient belongs in the operating room, and the treatment algorithm is to perform a FAST, then a pericardial window in the operating room, preferably under local anesthesia, with your patient prepped and draped, and then you proceed to a sternotomy and definitive treatment if the window is positive. Rachel, do I have a couple more minutes, or do you want me to stop here?
A couple more minutes, but brief, because we already have about 10 questions lined up. So for this.
Okay, well, I think, you know what, probably the questions are more important than anything I have to say here. I would just say that you can treat a cardiac wound with your finger, with a Foley catheter blown up, with a balloon blown up in a track, with a normal wound stapler, or with a suture repair with a 3-O-proline and plus or minus budgets. But I'll just stop here because you guys are more important than anything else that I have in here. So shoot, what questions do you all have?
Thank you. Well, we'll save all the questions for the end because there might be some overlap in topics. But thank you so much, Dr. Grudziak. And we're going to move on to Dr. Bradford Scott, who's going to be talking about abdominal trauma, laparotomy. Dr. Scott, if you want to share your screen.
Hello. Let me see if this works. Does that work?
Yes, that looks
Or
great.
do you see the slide view?
I see your view if you want to.
Yes, I can see your screen. I can also hear you.
Okay. I have 3 screens. This always has a problem. It's very nice to meet everybody. Brad Scott. I have was a resident here under Dr. Maddox, and have been faculty here for a few years, and have been working at Ben Taub my entire time. I get most of this talk from this book, which Dr. Maddox and Dr. Hirschberg wrote. Actually, Dr. Hirschberg wrote most of it. So Asher was a trauma surgeon, was faculty at the same time. And the way this book was written, he would sit and listen to our conversations at Morning Report. And he would talk to all the surgeons on how you fix this and how you approach that. And he was a very generous person. This is my actual book that Asher signed for me. And the trauma laparotomy section, he actually told me, he was just listening to me talk, and he goes, Brad, how do you do a laparotomy? He wrote it down, and that's what the chapter is. So that's why I'm borrowing the book back. So I'm going to go over a very simple, straightforward idea of how you do a laparotomy for trauma. You've already made the decision. You're going to operate on this person. How do you do it? So these are the steps: prep, drape, make an incision. You're going to pack the abdomen. You're going to explore the abdomen, find bleeding and stop it first, find contamination and stop it second, and then decide if you're going to do damage control, you're going to repair it, and you have to know where you're going. This patient has to have a location. They don't stay in an operating room. So prep and drape, this is straight from Asher's book. You drape widely. Never drape yourself out of an operation. Never, ever undrape patients. The way we've always done it is prep knees to chin. You cover the groin if the genitals, if you don't need access to them, if they're not injured. And then you place your towels all the way around to the patient. So you can open either chest, you can open the abdomen, you can get vein out of the leg if you need it. Everything's available. You make the incision. How the incision matters, you go down the middle. It's the incision of indecision. It's something you do all the time. You can go around the belly button, or you can go through the belly button. I've had a few faculty go through the belly button. I don't recommend it because it doesn't heal very well. It gets infected, not uncommonly. And the decision is which side. Most commonly in trauma, you're going to bring out a colostomy versus an ileostomy. So if you make your incision on this side, you have more room for a colostomy in the bag and the appliance and everything else. And so that's always been my advice. How to do this? It's very simple. Take the umbilicus, put your finger in it, pull to one side, make a straight incision on that pull from xiphoid to pubis, and then let it go back. And it will make this nice gentle curve around it. You don't have to do all these machinations and changing the knife angle. Just cut straight. And it literally is 3 swipes. It should be skin, subcutaneous tissue, fascia. 1, 2, 3 in one direction. And if you hold your knife, y'all can see me, right, Rachel? Okay, so if you hold your knife like this, not this. You hold a knife like this and you draw just like a bowstring on a violin. One incision, you can actually open a patient's abdomen very effectively, very quickly. And don't be afraid. Try to find the middle. The middle is always in the middle, which is where your umbilicus is. So if you want to find the middle, when you pull the umbilicus over the skin, let that go back, and then you cut right next to the umbilicus, that will be the midline. You'll find it every single time. So 3 swipes, skin, subcu, fascia, be done. And then Asher always said 3 swipes and an educated finger. So to get through the peritoneum, don't go through the peritoneum with a knife, you'll cut some bowel. I've done it. I did it Monday. Make your incision, you can stop the umbilicus. And what I do like to do is actually a pair of scissors. A pair of Mayos, Get them right at the umbilicus. You make an opening at the umbilicus, take a pair of mayos, and you push. You barely open the scissors, barely open the scissors, and push like you're cutting wrapping paper. And you'll see, if you stay in the midline, it'll unzip the abdomen both directions very easily. It's very effective, and you have less injuries in the bowel in this way. So you pack. How do you pack? Your hand is larger than any instrument you're going to put in there to retract. So don't waste time grabbing another instrument and pulling it in. Pick up the abdominal wall. Your assistant picks up the abdominal wall, and the other person on the other side packs upper quadrant, lower quadrant. Then you pick up the abdominal wall and they pack upper quadrant, lower quadrant. And you put the packs in to get the blood out. They're much more effective than absorbing blood than any suction. If you don't have packs and you only have suction, that's what you have to use. So it should be packed to the point where when you withdraw these packs, you're going to get 95, 90% of all the blood that's out. And now you've started. I personally put in a retractor. I have other faculty that do not. I put in a Balfour, a simple retractor, whatever retractor you have to hold the abdomen open. There's a lot of different fancy ones. I would not spend the time in a hypotensive patient putting a fixed retractor on the bed and Book Walters or Harrington's, all these crazy retractors. I would not do that. You've got your packs. You've packed all quadrants: right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. You packed in those corners, and then you have to make a decision. Where do I go next? It's a pretty simple algorithm. If it's blunt, make your best guess. If you think it's liver or spleen or bowel, which is the only thing that's getting injured in blunt, not the only thing, but you unpack all quadrants and you inspect for injuries. If you find an injury, say you pull the laps off the liver and you're like, that's injured, put the laps back, a new set of laps back, and then go to the other quadrant. And you isolate all your injuries. You very quickly figure out which one's injured. It's spleen and liver, or spleen, liver, abdomen, or pelvis. Penetrating, do your best guess to unpack away from the suspected injury. So say you have a gunshot wound to the right lower quadrant, I would start in the left upper quadrant, unpack that, that's not injured. Left lower quadrant, not injured. Right upper quadrant, not injured. So now I get to isolate the one thing that's injured and I can get to work on it. So once you do that, you're going to eviscerate the bowel. If you're looking for the aorta, you eviscerate straight up, straight towards the patient's head. If you're looking for the vena cava, you put it to the left side of the patient, left shoulder. So those two maneuvers will show you what these injuries are. So the very next step is what we've always said at Ben Taub and what Dr. Maddox has all taught us: big red, big blue. You're looking in the retroperitoneum for things that will kill the patient faster. You bleed faster from injuries in the retroperitoneum than you do in intraperitoneum. So you look for big red if you have a hematoma around it and it's bright red. It's not subtle, or dark blue. You know where these injuries are. So that maneuver alone will tell you exactly where you're at. Make a decision. Is it contained? So in blunt trauma, it'll most likely be contained. A ruptured kidney can rupture the retroperitoneum, but it's most likely not. So control, if it's contained, run your bowel, figure out what's bleeding from the bowel and the contamination. Get that controlled first, control your contamination, and then get after the retroperitoneal bleeding. If it's uncontained, that is what is going to kill your patient. So you want to get after it. And this is in trauma laparotomies, there's no waiting, there's no pausing, there's no, you need to have all these things thought in your head and you just do them very quickly. If you're going to get proximal control of the aorta, it's up near the head. Proximal control of the vena cava is in the pelvis. You can use compression or clamps, either way, either one. Zone 1s, you explore in blunt and penetrating. In penetrating, you explore zone 2 and 3. And in blunt, only if it's expanding or rupture in zone 2. So zone 1, get after them. You're eventually going to explore them in penetrating and blunt. And in blunt, zone 2 only if they're expanding or ruptured. And you can't, or you don't have another reason for their hypotension. Okay, then you figured out the retroperitoneum, run the bowel, run the entire bowel. Esophagus, start the hiatus, into the stomach. The way you do the stomach, lift up on the abdominal wall, put your hands on the stomach, flatten it out, and look at it. Look at every single part of it. Then run duodenum, look at the duodenum, run the entire small bowel, ascending colon, transverse, descending, sigmoid, and you've looked at everything. Look in the lesser sac. This is not the greatest picture. So you lift up on the stomach, you lift up on the transverse colon, and there's going to be a thin, wispy space in between. You can take your finger, poke them through, spread, and look. You can take a deaver, a curved instrument, and actually lift up the stomach and get all the way up in the all the way up. Look at the pancreas, that entire space. It's very easy to do. That will get you identifying every injury that's in the abdomen and the retroperitoneum. There's a couple maneuvers. And I'm not going to go over how to fix every single one of those. That's like that's a textbook. It's about this thick. Couple things that will actually get you in the spaces you want to get to. If you have a large retroperitoneal hematoma and it's mainly on the right side and it's above the transverse colon, there's one really great way to get it to there. Dr. Maddox described this when he was a fourth-year resident. It's a left medial visceral rotation. You take a pair of scissors, you hold the left colon towards you if you're standing on the right side, you cut the white line of Tolt starting at the sigmoid colon, and you just slide along the white line of Tolt. It should take you a couple seconds, and you slide it all the way up, and you grab the spleen and pull it medial, slide that all the way up until you get to see the left cruce. And then you take your hand and pull all the viscera up. And you have to decide either kidney up or kidney down. If you want to put the kidney in your hand and rotate the entire viscera medially, you'll see the entire aorta. If you drop the kidney, you'll see the anterior part of the aorta. Don't be afraid of it. The hematoma does dissection for you. This maneuver will identify the bleeding very quickly, and you'll be able to clamp it immediately. This is not something, it's not an advanced maneuver. This is straightforward. I teach fourth-year residents, second-year residents how to do this. It's actually, once you've done it once or twice, you realize it's actually not very difficult. The right side of the abdomen, you need to get to the retroperitoneum. You want to do a right medial visceral rotation. It's called a Cattell-Brosh. There's other people's names associated to it. Mobilize the duodenum, the right colon, and the ileocolic space, the ileocolic attachments. Those three things will flip the entire intestines out of your way, and you can see the entire retroperitoneum. It's a lovely thing to do. Start with a Coker maneuver, making an incision around the duodenum. You literally just pull on the duodenum, take a pair of scissors, snip it. The vena cava is right below it. You rotate the duodenum medial, true medial. You stand the duodenum up. Then you mobilize the right colon on the white line of Tolt. And what this does, well, you'll expose the right kidney, the entire vena cava, all the way down through the pelvis. Ileocolic mobilization is usually when I come in the room, they're like, we're struggling, we can't see everything. That's usually what they haven't done. You have to take down those attachments. Once you get those attachments down, you can flip the whole thing up. You'll see aorta, vena cava, both renals, anything you want to get to that's below the renals. Below the renals. So that is, those maneuvers will identify all your injuries. It'll get you in all the spaces you need to get to, and it should be rapid. Once you get control of these things, then you get back to this pace that you normally operate with, that you can fix. So prep wide, drape wide. Never drape yourself out on an operation. Never you have to move a drape out of the way to open a chest or something. You don't, it's a trauma patient. You don't know you weren't there. Unless you injured them yourself, which, you don't know exactly what their injuries are. You've never done this case ever before. 3 swipes and a finger, right in the middle, no small incisions. There's no small incisions, only small surgeons. So Don't fight through a tiny incision. You have to save this patient. Pack all 4 quadrants, hold up the abdominal wall. You explore big red, big blue, liver, spleen, bowel, lesser sac. That's all the stuff that's in there. Then you clamp. If it's bleeding, you can clamp it, you can ligate it, you can suture it, you can cauterize it. There's a lot of different techniques to do it. If there's contamination, which means bowel injury, you can clamp it, ligate it, suture it, and get control of it. Then you got to decide, what are we going to do? How long are we going to be in here? How much blood do I have? Who's taking this patient after I leave? And the basic principle is physiology dominates anatomy. If the patient is dying, you need to do the least amount possible to get them to a place where you can resuscitate them. So don't stand in the OR for 5 hours trying to fix something very complex while the patient's bleeding to death. Make them stop bleeding. And I go to parties and talk to people and you're like, hey, what do you do for a living? And I use the Marty Schreiber phrase, because I make people stop bleeding. That's what I do. That's what I do for a living. So that's my talk. Trauma laparotomy in 10 minutes or less. Leave time, and I wanted to be as basic and straightforward as possible. Leave time for questions. I will unshare.
All right.
Who's going to share?
That's definitely the best we've ever done in time. So kudos to both of you. First, let's start with Dr. Maddox. Do you have any comments or tips based on those 2 talks, Dr. Maddox?
Yes, a couple of things. The movement towards pigtail catheters to drain a pneumothorax and a hemothorax is moving very quickly. They drain pigtail drains just as good as a big catheter. Number 2, I really have been disappointed in the diagnostic capability or the usefulness of ultrasound of the chest for anything. I don't use it. Number 3, in the pre-hospital phase, needle decompression of a tension pneumothorax has been reported by a number of studies. It just doesn't work. The majority of the time, that needle decompression is not even in the pleural cavity. And this has been reported several times at the Las Vegas trauma conference. What you want the decompression to work. These have been 2 good talks, and they're on the procedure and procedures to help with the patient. If you put in a chest tube or you put in a pigtail and you have more than 1,500 cc's of blood, that person ought to be in the operating room with that side open and be prepared to staple a lung, sew up the lung, find out what vessel is bleeding. That we ought to save that for another day.
All right, sorry, I'm just adding some additional questions as well, but we can go on and start with some of the questions regarding chest tubes. So basic questions regarding tools. How do you choose which kind of tube size that you use, and the length, how far do you insert it?
So I think that was just addressed with the pigtail comment. I think I would just go with whatever you have. I think the data shows that if it's going to drain, it's going to drain through no matter what size of the tube is in there. And if it's not going to drain, then the size won't matter. So use whatever's available. I think I go until I meet resistance. 14 to 16 centimeters is usually okay for an adult. Let's see, I usually finger sweep as long as there's not significant trauma that would potentially compromise your own safety. I think if you have a lot of broken ribs or a lot of traumatic injury there that could potentially hurt you, then I would use this with caution. Let's see, adequate dissection of soft tissue during placement. I've used scissors, I've used hemostats, I've used Kelly's, I use whatever is available to get me into the chest quickly. you know, if you have time to mess around and give people a lot of anesthesia or a lot of local, then you can kind of make this really pretty. But I think the places where I've seen people go wrong is making the incision be too small, especially with big people, people who have a lot of subcutaneous tissues, and then just use whatever's available to get you into the right space. And then the other, I think, place where people who have not done this a lot run into trouble is where you're trying to get into the intercostal space. The pressure required is a little bit more than what you normally expect, I guess. Insertion of the tip upward or downward, I usually aim for up. But I think with chest tubes, if it's pretty, great, but really it's just meant to do the job. So if it addresses the pneumothorax or drains the hemothorax, then it doesn't really matter where it's facing. Pigtail, I use them in non-emergent situations because you don't want to be doing cell-danger technique in people who are crashing. But if you, you know, I think still getting into the chest with a chest tube is fastest in the trauma situation. But if you can wait a little bit or you can have the controlled setting, then a pigtail I think is better for the patient. And again, it does as good of a job. How do you decide how many bottles to use? I think it depends on whether you have evidence for a lot of fluid being present. If you do, then you want to have at least 2 bottles available because you want to have a different, you want to have an adequate amount of drainage available. Needle thoracostomy anteriorly or anterolaterally, it doesn't work either way. I think the reason why we've moved to anterolateral placement is more to just avoid any kind of inadvertent injury when you're stabbing people in the chest anteriorly versus on the side, because there's less things to injure there. Finger or Foley for a cardiac wound. I think it's a finger if you can spare it. If you don't have the availability of using more than your own hands, then I would put something else to hold this closed while you're getting yourself ready to be prepared to address it. But I can leave this open to more senior members of this discussion team. When do you remove the tube? For a pneumothorax, I usually do it 24 to 48 hours, depending on the associated fractures and whether or not you still have an air leak. A hemothorax just depends on how much is draining out of the tube and what associated injuries the patient has. Okay, I'll stop there for a sec. And if somebody else wants to take this or comment.
Yeah, any comments, Dr. Scott or Maddox, on chest tubes?
I have one. We're using the colloquial term pigtail. Does everybody understand that it's a linear drain that you put in with a wire? You know, I don't know if it's a a local term, but not a chest tube. They work just as well. If it's liquid, it's coming out. If it's not liquid, you need to take it out physically. So.
All right.
What is your preference for finger or Foley for a cardiac wound?
If like you said, if it's just you and you put your finger in there, you're not moving. You can't do anything else, right? The only problem, the Foley, you can make the wound larger. Don't blow it up. Just barely blow up the balloon just enough to tamponade it to hold it, because you'll occlude the lumen of the heart, right? It's not that big, so you got to be really careful. Typically, I just put my finger on it, but we have a lot of help, right? You know, if I was out in the middle of nowhere with nobody, I had to go get instruments with my other hand. That'd be really tough.
Yeah, since we do have a little bit of time, do you want to mention other technical aspects of cardiac wound repair?
I have a comment. If lacerations of the wound, gunshot wound to the heart, or laceration of the heart, when you sew it up, I saw your slide, plus or minus pledgets. We've argued that for years. This is going to show your true technical skills. The heart muscle is like sewing on wet butter. You have to go direct. You have to follow the path of your needle. Any variation in your needle while you're sewing it, you're going to start tearing the heart. And when you tie it down, it's just tight enough to occlude the wound. You can easily take a stitch through the heart and just tie it to where it rips all the way through. So you have to be very gentle, very correct, very direct. they're not going to survive if you don't sew it up. So sew it up. Just be careful. I've seen a lot of people hover and be afraid to suture it. You have to suture it.
All right, so let's move on to some decision-making questions. If you have an unstable patient, they have both chest and abdominal trauma, how do you go about the decision-making, where to make your first moves?
I would recommend going in the belly first, always. The real threat to life is usually in the abdomen. In a study that Hirschberg did for thoracoabdominal wounds, the wrong cavity was entered 50% of the time, and most often that was the chest. So it's put in a chest tube, use those decision making on thoracotomy, volume of blood, but go in the belly. And that's usually where the money is. What do you think, Brad?
I agree. Since you taught me how to do this, yes. I'm going to agree with you 90% of the time. And that you put a chest tube in, watch the output, be wary of tamponade. If you have an injury in the chest, it's actually tamponade, you need to take care of that.
What about a needle? What about a needle decompression of the pericardium?
If you have to. If you don't have surgical capability and this is all you get, all you have is a needle and a syringe.
It doesn't, it's usually already clotted, and you usually can't get it out with a pericardiocentesis.
Correct.
The last question here, do you require a CT despite a positive ultrasound? If you have a positive physical exam, you don't even need an ultrasound, and you go straight to the operating room. Once you have decided to go to an operating room, you don't need any other test in the emergency room, and the CT becomes redundant. So the answer is no. Over 85% of CTs done in the United States do not alter decision-making and ought to be eliminated today.
All right, one other decision-making question that someone just asked, how do you go about approach in terms of a mediastinal gunshot wound and location?
A mediastinal traverse is a very difficult decision. In that case, a CT might be helpful in knowing whether or not you need to operate and where you cut. You're worried about the esophagus, the aorta, the vena cava, and the heart. If you encounter a transmediastinal gunshot wound and you have not been there before, I would recommend you really open them up widely with a clamshell incision, and then you can see both sides. Clamshell is a bilateral anterolateral transsternal anterolateral thoracotomy. You will need either a Lipsky knife or a Giggly saw to get through the sternum. But clamshell for a mediastinal traverse is a very good incision.
All right, and are your incisions or approach considerations going to change based on if you're in a hospital versus if you're in the field?
No.
Is this the 10% difference between Dr. Maddox and Dr. Scott right here?
You have to, whatever situation you're in, whatever low resource environment you're in, you have to do the best you can. And if you have every instrument, every blood bank available, there's things you can do where you don't have to temporize them as much.
The first question on chest tube says, what about the battlefield environment? I don't think I would put in a chest tube of any sort out in the field. I would get them to the hospital first.
If they're dying of hemothorax or tension pneumothorax, you need to decompress them in some way.
All right, how?
If you have a tube, put it in. You can do a finger thoracostomy and decompress them acutely, and then put a 3-sided dressing that Dr. Grudzyk showed, and then transfer them to the highest level you can get them to.
All right, let's move on to some laparotomy questions. So what blade do you use, and what actual items are you going to need to have to do a damage control laparotomy?
10 blade or 20 blade. If you have a 20 blade, they're very helpful. They're very large. 10 blade at minimum. And then what do you need? Laps. And then after that, it depends on if you're fixing bowel, liver, everything else. The nice thing about trauma surgery, you only need, some silk, some Vicryl, maybe PDS if you want that, something to close the abdomen, and then something to sew up a vessel. So only a couple different sutures. And so you don't have to carry a lot of instruments. Staplers, if you got them, that'd be great, because it makes it a lot faster to take out bowel. Did we lose Dr. Joe?
She's still here. She's just not able to put on the video, but she texted me that she's still able to respond to questions.
Oh, okay. Because we're talking too much. She needs to, she knows this much as we do. So.
All right. So can you talk a little bit about your technique for liver packing? How much packing do you need? And can you describe your sandwich method?
Yeah, absolutely. So sandwich method is you have a vena cava and then you have a liver. So if you pack so much below the liver and then above the liver that you can compress the vena cava, the patient will have no return to their heart. So you can actually make them hypotensive from this. So on the lateral edge, on the patient's right side, you pack next to the vena cava, and you pack on the other side of the vena cava medially, and then you can pack anteriorly in any other anatomic direction you need to do. So you kind of make a bridge around the vena cava so you don't compress the vena cava. And then you pack the direct anatomic injury that you need to find. If it's on the left lobe, pack the left lobe. Don't pack the whole liver if the right lobe is not injured. If the right lobe's only injured, don't pack the left lobe.
All right. In terms of retroperitoneal injury, can you have an injury without any solid organ or hollow viscous injury if you have a gunshot wound?
Yeah, there's plenty of things in the retroperitoneum that bleed. Any of the vessels that you can bleed. There's very large veins that live in the psoas. They're actually very large and they'll actually bleed significantly. All the investing vessels that go around the iliac in the ilium of your pelvis can actually bleed quite aggressively. So you can still have large amount of bleeding and just soft tissue damage alone.
All right, so say you're in the abdomen, how do you decide whether you do a left or a right medial visceral rotation, or what maneuvers to approach the trauma first?
Big red retroperitoneum, which means you have an aortic injury, you go to the left, patient's left. Big blue venous injury, go to the patient's right, do a Cattell-Braasch. If you have both, you can do both maneuvers, but you can't really get to the vena cava from the left side. The Cattell-Braasch, if you do it correctly, will get you aorta, vena cava, all the way up to the renal veins. So if the hematoma is above where you believe the renals are, go from the left on that side. I don't know what. I see shaking head.
Yep. I agree.
All right. So when you're in the OR, how do you decide whether to do a definitive repair versus just a damage control operation?
Like I said, it's physiology. If the patient is tolerating the operating room, and you have resources in the operating room to be able to fix it, and they're not too hypertensive, and their blood has been resuscitated, you can go to a definitive repair. You can take as long as you want to fix it. The best example, single gunshot wound to the abdomen is just a bunch of small bowel injuries. They were never hypotensive. Do your definitive repair and put them together. If you do bowel anastomosis in a hypotensive patient, it's a high likelihood it's going to leak. So it's kind of a waste of time. You're kind of, actually putting them in harm's way by doing that. You should resuscitate them and then fix the injury later. So.
All right. And if you have a stable patient who has penetrating abdominal or lower chest injury, how would you assess that patient?
Do you have any imaging? Stable patients, you can image all you want. You can take any pictures, CTs, ultrasounds, whatever you wish to do. If they're stable, low probability that they have a vascular injury that they're bleeding from. So you can try to investigate. It all depends on what your abilities are. We have expanded, I'll give Joe's opinion on this. We've expanded our use of laparoscopy in trauma, which was, for a long time was kind of poo-pooed and didn't, Rao Avituri's paper kind of put it to rest in '94. And we've reinvestigated, because all of us have much higher laparoscopy ability now from training. So we use laparoscopy way more than we've ever have. I don't know what in Utah.
Yeah, we do too, if we're able, obviously. I haven't been taking care of many stable patients that would fall in this category, but yes, if I can, I will use it. Yeah, I think with this, I agree. I think scanning would be helpful if you have access to it. If you don't, it's penetrating abdominal, I would just go to the belly, and then you can evaluate the diaphragm that way too. Place the chest tube if you need it.
All right, one more question about laparotomy. Do you do empiric packing always, or do you only pack in instances of active bleeding?
When you make your incision and there's blood, which is the reason you're there, right? The reason, it's really unusual to do well, you can do a negative laparotomy. I've done plenty of them, trust me. You make your incision, you pack, get the blood out so you can see. The problem, if you got 2-3 liters of blood in the abdomen, you're not going to see anything. You're not going to be able to do anything. I don't see underwater very easily. So you have to get all the blood out. I don't know if that answers the question.
I think the only time that I haven't done it is if I've had, free air on a CT and I've taken people to the OR for free air for some kind of traumatic rupture of a hollow viscus, and there is no obvious bleeding, but that's the only time that I haven't really empirically packed. If there's blood, I pack it.
All right, and we have 1 minute, so I'm going to end with this heart-stopping question. So if you have a patient who's losing a pulse, do you immediately go for a thoracostomy, or do you start chest compressions while you're preparing for your OR?
We're in the ER.
Maybe you can address it. They didn't clarify. Maybe you could address it in multiple settings.
Yeah. If you're not in the operating room, the patients they're still awake. I've done one awake thoracotomy. I don't recommend it. Yeah, it's kind of frightening. We didn't realize they were awake. Sorry. I apologize later. If they've lost their pulse, then you move to thoracotomy, clamp the aorta, resuscitate the patient. If it's a penetrating injury, blunt, you're not going to get a lot of survivors when you do that. We have done it. We have a few survivors from it. It should be very selective. We have been very, and I know I'm going to say this word, and Dr. Maddox is going to whip his head around. We have used the Roboa device a few times with some partial success. I don't know about Utah. Have you all used it very often?
Not so much. We're trying to move more toward, we get a lot of obstetric hemorrhage. So for that, I think that's a great indication, but I like the idea that your finger is a much better control of intra-abdominal hemorrhage than a Foley. And I think or than a catheter. And I think it does take away a lot of time. You spend a lot of time kind of you should be able to do a lot of other things while you're getting access in the groin, but I think practically in my experience, it's just better to do it in the OR. But
I totally agree with you. completely. I have not been very impressed with its abilities. So in the amount of time it takes to do that.
There is a systematic review recently that came out that said it was associated with higher mortality, but I mean, it's hard to, I think it's really hard to really match these patients. But
Yeah, well, Joseph's work. I agree with you.
So I think the Reboa is a expensive instrument of the devil, and any survivor of the Reboa probably didn't need it to begin with.
Was incidentally treated.
All right. Well, thank you very much. And thank you to everyone who sent in questions and who's sent me information about your context. It's very helpful to tailoring these sessions to what's useful to you guys. Again, like always, we just want to extend our support to everyone who's going through really challenging circumstances. And thank you for being here despite challenges in electricity and internet. So please send me an email if you have any questions or comments about how we can make the sessions better. And we'll see you on the 19th next. All right, and I'll put
Joe,
in the chat.
Yeah.
Yep.
Joe, tell Dan Virgo I said hi. It's a good friend of mine.
okay, we'll do. Have a good
Bye-bye.
one. Bye.